Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners, and welcome back to the pod. Today, we're talking about a topic that matters for boards, matters for the OR, and for the future of nurse anesthesia practice. We are talking about emerging anesthetic drugs. What's new? What's hot on the market? And specifically, we're breaking down three big names: Remimazolam, Sugammadex, which we know and we love so much. My anesthetic bestie. I can't live without Sugammadex. Bridian for life. Novel opioids, including oliceridine. I'm pretty sure that's how you say that. Now, why do we care? In anesthesia, we love the following pharmacology type medications, right? In anesthesia pharmacology, we are always chasing the same dream. We are chasing a faster onset, a faster wake up, a more predictable recovery, better hemodynamics, safer profiles, easier reversal, and less quote unquote cleanup afterwards, right? We're not chasing our tail. We're not having these delayed emergencies. Basically, we want drugs that work beautifully, wear off cleanly, and don't cause chaos in between. Like I always say, in anesthesia, we don't have a crystal ball or a magic wand. I feel like these drugs are like the closest we'll get to having a magic wand, but nevertheless, here is the clinical truth. Just because a drug is smart on paper does not mean it wins in real life, right? Cost matters. Availability matters. Provider comfort matters. And I'll talk about that when we talk about Sugammadex. Hospital formulary matters, definitely. And outcomes matter. So today, let's break down the way you need to know these for boards and the way you might actually use them in practice. So segment one, we are going to talk about Remimazolam. Midazolam meets remifentanil type of energy. So let's start. If midazolam and remifentanil had a pharmacology baby, this would be it. It's a benzodiazepine sedative, hypnotic, with ultra-fast metabolism. So yes, works on those GABA A receptors just like midazolam or our friend Versed. This means sedation, anxiolysis, amnesia, hypnosis at higher doses. Nothing revolutionary here. We know our benzos well. The magic is in the metabolism of it. So why Remimazolam is different? So Remimazolam, I bet you could guess it, has an ester linkage. That means that it gets broken down rapidly by the non-specific tissue esterases and not dependent on the liver or the kidneys. Anytime you hear organ-independent metabolism or that ester linkage, right, your ears should perk up, because that means that the drug is more predictable for recovery, we love, less accumulation, we love, better option in hepatic or renal dysfunction, we love, a cleaner wake-up after longer infusions. Wow, that is why we get excited about this drug. So let's talk about the actual pharmacokinetics. The onset of Remimazolam is 1 to 2 minutes. It has a short context-sensitive half-time, which is great, a fast recovery, still reversible with flumazenil. And let me pause here. That last point matters because propofol does not have a reversal agent. So if you overshoot propofol, you have to wait. We know this. That volume of distribution in the adipose tissue, you could be waiting for a very long time if you don't titrate your propofol drips accordingly, especially if you're doing a full TIVA. If you overshoot Remimazolam, you have a tool in your back pocket. That can matter in difficult airways, elderly patients, frail physiology, or unexpected oversedation. Wow, amazing. If only propofol had a reversal agent, that would be incredible. We'd be rich. Let's come up with one. Let's get in the lab. What evidence suggests? So compared with propofol, studies have shown with Remimazolam that it has less hypotension, less bradycardia, less pain on injection, and often less respiratory depression. That hemodynamic stability is the headline. So imagine your frail 82-year-old is coming in for a GI procedure. She has a soft blood pressure, mild aortic stenosis, limited reserve, but that's where Remimazolam becomes an interesting and viable option. But it's not perfect, right? But there has to be downsides to anything we do in life in general. So here we go for Remimazolam. We know the downsides. Delayed emergence still can happen, especially with older age, higher BMI, low albumin, variable esterase activity, resedation after flumazenil. which we know can happen. If the antagonist wears off before the sedative fully clears, which we know. Hypersensitivity and anaphylaxis is rare, but it has been reported. And probably the biggest downside of this all that's going to make it affect patients the most initially is the cost. A lot more expensive than propofol or Remimazolam. And this matters because hospitals don't buy drugs based on how much anesthesia loves them, unfortunately. Although maybe they should. Just kidding. Clinical parole. If they ask which sedative offers benzodiazepine effects with esterase metabolism and reversal with flumazenil, the answer, Remimazolam, our new friend. Hopefully coming to a hospital near you. I haven't seen it in clinical practice. Part 2, let's talk about our bestie Sugammadex, or Bridion, right? The drug that changed reversal. This medication truly changed the trajectory of nurse anesthesia practice in general. In my opinion, it's made everything much safer, much less costly, even though Sugammadex is costly because we know OR minutes are so expensive. And using Sugammadex helps reduce OR time. Before Sugammadex, if you wanted to reverse paralysis, you usually used our old besties that we've left in the dust, most of us. Some places still use these because, again, they are cheaper. Neostigmine plus glycopyrrolate or atropine. And it worked sometimes beautifully, sometimes slowly, sometimes awkwardly. And we were having to monitor patients much closer in the recovery room for residual neuromuscular blockade, that floppy fish look that a lot of newer clinicians may or may not even be able to recognize because they haven't seen it and they've used Sugammadex so much, which is a blessing, but you should still be able to identify residual neuromuscular blockade. And you should also know how to do the traditional reversal of neostigmine and glycopyrrolate. The mechanism behind Sugammadex is my favorite. It's that classic picture of the molecule surrounding the rocuronium molecule, fitting it perfectly, and you literally urinate the complex out. Sugammadex is a modified gamma cyclodextrin. Think of it like a molecular cage, right? Like I just mentioned. It surrounds and binds to that rocuronium and vecuronium molecule, although it fits better with rocuronium, is my understanding. Then pulls them out of circulation. That creates a concentration gradient and more neuromuscular blockade leaves the receptor. The result? Goodbye paralysis. We are back and stronger than ever. And here's the key distinction. It does not inhibit acetylcholinesterase, so no cholinergic flood. No need to balance muscarinic effects like our old reversal agents, neostigmine. That means less bradycardia, secretions, bronchospasm, and GI stimulation, which is the side effects of our neostigmine and our glycopyrrolate, our old, quote unquote, or OG reversal agents. Why everyone loves it. Okay, this is how we titrate it and the way that we calculate the dose for patients. If they have a moderate block, they get 2 milligrams per kilogram. If they have a deep block, 4 milligrams per kilogram. If you need immediate rescue reversal after RSI with ROC, we give 16 milligrams per kilogram. And it works fast, like really fast. Deep block reversal in minutes, and that's a huge deal. So again, why does this matter clinically? Imagine you're closing a laparoscopic surgery. The surgeon says, we're done. Patient is still deeply blocked. In the old world, if this happened, we would have to wait because you could not reverse with neostigmine and glycopyrrolate safely unless the patient had 1 to 2, preferably 2 twitches, right? So it maybe not be enough. The neostigmine would not be enough in this. In the new world, we're giving Sugammadex. That improves workflow. It improves safety and confidence. Boards love these risks associated with Sugammadex. Anaphylaxis can happen with Sugammadex. I haven't seen it, but it can theoretically happen. It happened in the studies when they did the studies for the drug. Rare but real, marked bradycardia can be severe, even cardiac arrest reported. Coagulation changes, transient increase in PTT at higher doses. You can have a reoccurrence of the block. Renal failure concerns. The drug is renally excreted. I just said that you urinate it out, right? So if you have a patient that is anuric, this medication may not be the viable option for this patient. You should use with caution, especially for those anuric patients. Oral contraceptives. This is a huge thing with Sugammadex. It actually reverses oral contraceptives. And this is classic questioning for Sugammadex in terms of boards or exams. Sugammadex does bind to steroid hormones. Patients using hormonal contraception or birth control, oral birth control, need backup contraception for 7 days. That's an easy test question and an easy real-world miss. When Sugammadex first came out, I'll never forget, we really had to do a lot of PACU nurse education because I would say, I gave the patient Sugammadex just to let you know. And they would be like, okay. And I'd say, well, you got to educate the patient if they're on oral contraceptives to use an alternative form of birth control for at least a week. And the nurses didn't know initially that it existed. Having those conversations and educating our colleagues is really important to provide that safe patient care. So if they ask, best reversal for deep rocuronium block, Sugammadex. If they ask, does Sugammadex reverse cisatracurium? It does not. So if you use Nimbex, Sugammadex will not help you at all. It is the molecular structure of our steroidal neuromuscular blockers is the reason why Sugammadex works. So for our non-steroidal benzoquinolones, I'm pretty sure that's how you say it, like Nimbex, or cisatracurium or atracurium, Sugammadex will not work for those medications. So that is very important to note. Part 3 of this podcast, we're going to talk about some novel opioids. So can we separate analgesia from its side effects? That is a huge thing with opioids, and the huge wave of opioid-sparing anesthetic techniques is the side effect profile, and we're trying to avoid all of that sequelae because patients do better without them. So let's talk about the opioid dream, right? We can get pain relief and lose the respiratory depression, the nausea, the constipation, the abuse potential. And that is where biased agonism comes into play. Let's talk about biased agonism, simplified. Traditional opioids activate those mu receptors and trigger multiple pathways, right? We know this about our opioids. One pathway gives the analgesia, right? Another pathway contributes to that respiratory depression, nausea, tolerance, and constipation. So scientists asked, what if we could do bias signaling towards the analgesia and focus on analgesia only? That led to oliceridine. So oliceridine is this FDA-approved IV opioid for acute pain. The hope is that it has good analgesia, less respiratory depression, better tolerability, but then reality happened. Let's talk about the real-world problem. The respiratory depression still occurred. The QT concerns still existed. Schedule 2 warnings remained. The nausea still existed, and it cost more. The benefits were modest, and eventually it was discontinued commercially. That's such a good lesson for anesthesia learners because a drug can be scientifically amazing, and the goal is 10 out of 10, but if it doesn't clearly outperform cheap existing drugs, adoption is hard, right, when it comes down to it. So maybe in the future, they'll be able to pinpoint a medication that truly focuses on the positive side of the opioid profile and takes away the negative. Big takeaway. The concept isn't dead, but people are still pursuing this type of opioid. With better biased agonists, mixed receptor drugs, peripheral opioids, endogenous opioid enhancers, but for now, traditional opioids and multimodal anesthesia and analgesia still rule practice. So we are not giving up on our dreams of the perfect opioid, but this was out there and discontinued, and we will continue to do our block and Precedex and non-opioid anesthetics, right? So let's do a little rapid review as we wrap things up with these new and newly discontinued medications. Remimazolam is a benzodiazepine. It is a GABA-A modulator. It has that esterase metabolism due to the ester linkage in its chemical structure. It is reversible with flumazenil, which is the huge win here. You get less hypotension than with propofol. To summarize, Sugammadex, it encapsulates roc and vec, not Nimbex or cisatracurium, right? It reverses the deep block rapidly. It has no cholinergic effects. We still watch for bradycardia, anaphylaxis, and contraception counseling. In terms of oliceridine, womp womp, it is that biased mu agonist that is now discontinued. The goal was analgesia with fewer side effects, but had real-world limitations to it and was pulled from the market. All right, final clinical pearls here for my favorite learners. The newest drug is not automatically the best drug, right? We saw that with the opioid we just discussed. The best drug is one that matches the patient in front of you, the physiology you're managing, the resources you have, and the risks that you understand. That's the art of anesthesia, not memorizing drugs, but applying them and choosing them wisely. All right, my favorite learners, if this episode helped you connect some pharmacology dots, send it to a classmate, which if you're on my courses, you're listening to this anyways, and your classmates already have it. Share it with a colleague or save it for boards review week. That is my goal for these podcasts, is that any SRNAs across the nation can save these, do some weighted vest walks. My students are probably rolling their eyes because I talk about weighted vest walks like every week. Go on a walk, listen to my voice as I soothe you towards boards to pass that NBCRNA NC. And remember, we're not just learning drugs, we're learning about the decisions we make as anesthesia providers and how to make the safest, best decisions for our patients. We'll see you in the next episode. Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.